Good afternoon, everybody. My name is Wendy Rees, and I'm an improvement manager with the Emergency Care Improvement Support Team. My dog is barking, as usual, the minute I start the webinar, as loud as he possibly can. Hopefully you can see the screen. I'm just going to do a couple of intro slides and then I'm going to hand over to today's speakers. Thanks everybody for coming, and hopefully you've got some water. Keep hydrated and please go and get some water and drinks during the webinar. I just want to start by saying this is our Frailty and Deconditioning webinar, our learning event 2. We had one a couple of weeks ago where we talked around a model for understanding frailty pathways. And today we're moving on with this webinar. This is a collaborative that we've organised in response to the Hospital Only Discharge National Programme. This is one of the work streams within that. Workstream 1 is around hospital only discharge. And 15 organisations have been supported through that programme. However, these webinars are open to everybody. The collaborative is focused on 4 key areas, which was from feedback from the sites that are part of that programme. So what they wanted us to share with them was supporting operational processes, board and board rounds, frailty and deconditioning, and workforce. So there are 16 webinars in all. This is the Frailty and Deconditioning workstream, and there's 4 webinars for that one. You can access all of the webinars on our platform, and I'll share that with you later. Around this collaborative approach that we put in place, these are the learning events which support the trusts who are in that national programme in terms of the improvement that they've identified. And alongside that, they get some QI coaching, some clinical coaching and access to expert resources. You will, or anyone on this webinar who's not part of the national programme can access our resources as well, no problem at all. As I said, 4 events per theme and they're clinically led. And today we've got a doctor and an occupational therapist to share their experiences with frailty pathways with you. The workstream really is about showcasing and sharing good practice, really just to help you understanding timely discharge for frail older patients and the home first principles, using frailty scoring where we can to identify those with frailty. And again, using sustainable data to help you develop your changes. And we're going to talk a little bit more about that today. So Jyothi and Sarah will go into a little bit more detail about the data they collected and raise awareness of system-wide frailty. So although the national programme on hospital only discharge looks like it's just hospitals, of course it's not. And we know that actually getting people home and stopping people from going into hospital is everybody's work. So today, pleasure to introduce Jyothi Nippani. She's an Associate Medical Director in Warwickshire, and she's also one of our clinical directors. And alongside it is Dr. Sarah Mercer. She's a trainee consultant practitioner for frailty. She's an occupational therapist and works in Southern Health Foundation Trust, which is a community provider in Hampshire. We're going to talk a bit more on this webinar about how to implement change. We're going to talk about continuous improvement approach and how that can be used to implement your change, and also how we use data to support your case for change. I'm going to stop sharing now and I'm going to hand over to Jyothi. If you put your questions in the chat, we'll try and pick them up as we go along, and we will have time at the end of the 2 presentations today to pick up any questions there. Thanks, Jyothi. So I'm going to stop sharing now and over to you.
So good afternoon, everybody. I'll just set myself up and okay. Are you able to see the slides? Brilliant. Okay, so what I'll do over the next 20 minutes, if that's okay, is to take you through some things about frailty and a bit about our personal journey in frailty here in South Warwickshire Foundation Trust. So the vision for frailty, you'd probably agree, is that we need to get to this place however we can actually. So to get to care at home, which exactly what Wendy has just alluded to. So not everyone we can't support everyone at home, but wherever appropriate, we should absolutely aim to have this support at home with all these wraparound services working collaboratively to provide that primary care, secondary care, our community services, social care, and our paramedics, everyone working together to make that possible. So why frailty and how frailty actually impacts on flow? A few facts. If I go into the detail, I'll need more than 20 minutes. So these are the headlines which are actually hitting our newspapers now, where ambulances are not able to get to our patients at home when they have things like myocardial infarctions and stroke, because most of the ambulances are queuing outside our EDs. And why are we in that vicious cycle? Why are we in that place now where we are not able to get the right help to the right person where they need? And there's a little bit, and again, we said about care at home. And so it also means that where we see that a patient doesn't need an admission, how can we avoid that admission? And what are the harms that we do when we actually have patients who are admitted unnecessarily? And so I know you may have heard this before, but I will go through this again because it's really important that we realize the harm that we do for patients who are not needing to be in the hospital, not just for the person who is there on a hospital bed. That's the first person who is actually harmed, who doesn't need that bed or who has overstayed their need. They get deconditioned, they end up staying for long length of stay, they catch COVID, and that's happening again now with the rise in COVID infections and dying in places where they don't want to die. They don't want to die in hospital. So that's the first harm and the first person who is harmed. Then is the person in your ED perhaps on a corridor, on a trolley, waiting for that bed. And we know that there is significant harm if they're waiting for more than 12 hours. And then it is that person on the back of the ambulance who is waiting for even that trolley to get into your secondary care system. And there are instances where these patients have been cared at the back of an ambulance for more than 33 hours, which is not what is supposed to happen. And then there is this patient at home who's waiting for that ambulance and patients who are dying at home. So apart from these 4 patients, the staff looking after all these patients are really not happy at all. They don't want to provide this sort of care. So it's such a spiral of things, and we need to break that vicious cycle somewhere. So what is the data or evidence to support the principles of care in frailty? This is the national picture of the time spent in ED by our patients, and this is the reported time, and the actual time, I'm told, is actually much more than this. So this is just the reported what we have actually in our data. So on the x-axis here, you've got is the age of the patients, and on the y-axis is the time they spend in our ED department. The gray bars below the line are the non-admitted patients, and the blue bars above the line are the admitted patients. And what that shows very clearly is that as the age increases, whether the patients are admitted or not admitted, they spend significant amount of time in your ED. So typically a non-admitted patient stays for 6 to 7 hours, and an admitted one normally stays for around 11 hours or 12 hours or more. And as I said, these are the reported ones. So if you have an ED, let's say, which has got around 14 or 15 cubicles, and by your 11 o'clock to 12 o'clock, the peak of your first peak of your frail older patients coming into your ED, you already have almost half your cubicles occupied by these patients. So you can see the ED flow is completely shattered just because you can't get into this patient. Even if you don't want to admit them, they still occupy the cubicles for 6 to 7 hours. So ideally, ED is not the place to see frailty. If you can take frailty out of ED, it is the best thing to do really for the patients as well as for your ED. And the moment we did this way back in 2018, this is what happened to our ED performance. You can see the significant change in your ED performance because of that. And it's not because we want to do that. It's mainly that the patients actually get better care both ways. Our frail older patients get the best care where they are being looked after, and the rest of the patients also get good care and they get timely treatment. So this is what you can actually do if you take frailty out of ED. The next thing is about the emergency bed day usage of our frail older patients. Again, the x-axis is about the number of is the age in age group, and the y-axis is the proportion of patients in each of these age groups. Now, the gray bars are the percentage of the population of the various age groups, and the dark gray bars, or the dark ones, are the bed days they occupy. And it's very clear very quickly that in the older age groups, the numbers or the percentage of them in the population is very small, but the bed days they occupy is large. So you can see over 70s, typically, they're only 13.5% of the population. They contribute to around 22% of our ED attendances. They take up 30% of the ED time, and they occupy 66% of our beds. So you can see how significantly they affect the bed usage. And the reason I'm talking about this is when you set up frailty services in your hospitals, there is a good chunk of physical space and a lot of workforce that is given to the frailty services to manage the patients. And they will get criticized for seeing small numbers. They'll say, look, we have spent so much on frailty, they're only seeing 10 to 12 patients a day. Yes, they will only see 10 to 12 patients a day, but the impact on the beds by using it really well or doing the frailty well is great. So this is the argument in your trusts to actually support the frailty services because they will have a big impact on your bed usage. So this was our frailty journey, and it's a little bit of value stream mapping. If this was the process mapping for a typical frailty journey in most hospitals, and I've seen that in a few of the visits I made last week, this is exactly how it happens in many hospitals even now. So most patients come, however they're referred, our frail older patients come via ambulance into the ED, into acute medicine, and into a frailty ward, and then perhaps go home from there. And this is what used to happen in our trust too, pre-2016. By 2018, we took out acute medicine from it, at least during the between 8 and 8, we took it out, and patients were being picked up straight from ED and were brought to the frailty unit straight away. And by 2019, we started working with our paramedics, and we took out ED as well, where we could help, and we started getting our patients dropped in the frailty ward. And this is what actually gave that the previous SPC chart I showed on the ED performance. So you take frailty out of ED and your ED works very well. And by 2020, we were trying to get to our vision of managing patients at home when COVID hit, and it forced us to do that pretty quickly because patients didn't want to come to us, and we didn't want them to come to the hospital either. So it forced us to get to our vision quite quickly. So how did we manage that? So along with actually having changing the physical space that the patient comes to, there were lots of process changes also that we did along with that. So what were the process changes? So it is getting the patient seeing the right team first time. So before, all the referrals, as I said, they came, and they were post-taked, came through ED, and they were post-taked all by acute physicians. And we had a frailty advisory service which went into the acute medicine unit, and then they offered frailty service as a referral service. And they were transferred to a care of the elderly ward eventually at some point and discharged by them. So that was what used to happen. But the effect on that for the patient was that the patient saw the right team pretty much very late in the journey, and what it ended up doing was too many, patients being too many admissions and patients being over investigated. The process we changed was once we said, took patients directly to frailty, the patients were seen directly after referral by the care of the elderly team. The consultant was there along with the MDT, and what they did very early on in the patient journey was made sure the investigations were appropriate, and also made sure that the patients could go home if possible. So increased use of SDEC and less of admissions. So what led was the eventual result was less patients actually needed admission and more were managed as same-day emergency care. And I've got lots of charts to show you what we did. So there was a parallel post-take, and they were admitted directly under the care of the elderly, and they were discharged by the MDT team. Now, I don't know in your hospitals what stage you are in now, but these were our steps in our reconfiguration, and maybe they will apply, some of them will apply to you. So how did we use the physical space? So this was originally how we started. So all patients coming via ED, being dropped off in ED, and if the medical take was around 60 patients a day, all the patients came into one common space, which was the acute medicine, which had around 56 beds. So what we did very early on, as I said, is because these patients are already there in the system, they are not new patients, remember, they're already there in the system and they're all mixed up in our acute medicine and going to wrong places. So what we did is the same footprint, we just divided into two. We cohorted all our frail older patients to one side of the ward, called it a short stay frailty. We put all the MDT there, and so that they get this good wraparound service around them, and you don't have to bleep and do safari ward rounds anymore. They're all in one place. Communication is much, much easier. And those 60 patients who were all making their way into one place, we divided them into two queues. It is like opening another checkout in a supermarket queue, so that you actually start getting your queues move faster. So you're a younger high turnover patients go to one side and your older patients go to the other side. Now, have a look at the numbers. 50 patients on one side and 10 on one side. And this is exactly what will happen. This is the criticism frailty services will always get, that look, we have given you so much space, you're only seeing 10 patients. Yes, that is exactly what will happen. But doing it well will actually have a good impact on your beds, as I said, as I showed you before. So the more we started doing that, actually separating the queues and putting consultants and the team in the right place, we started creating our own space for our SDECs. So the medical SDEC was created and the frailty assessment. So we could actually lose one bay and convert that bay into an assessment unit. So remove some beds and put some, chairs and recliner chairs in that, and made it a frailty assessment unit. And of the patients who came here, 10 patients, 5 we were able to send them home the same day, only 5 needed admission, whereas before all 10 would need an admission. And these are just rough figures, just to make things simple, but yes, pretty much similar numbers you will see. And in the acute medical side, again, same 30 patients on being admitted and 20 being managed as a SDEC. This was our journey. But the better we did frailty, the better we were at our front end, the better we were at managing the patients in the first 24 to 48 hours. We created more space in the same assessment unit and converted another bay as well into an assessment unit. Now the current thing, what we want to do is to actually move these patients into the community. So this is our current, journey. Wow. So what did we do in the process to change that and make our patients actually stay in the community and look after them? So you saw earlier on, it was the right team taking the referrals after they came to the hospital. But what we changed is this red circle. Now the referrals come straight to the phone of the consultant who takes the calls. So this is even before they hit the ED. So while they're still being referred, they take calls from 999 GPs and sometimes ED consultants. But then the calls, what they tend to do, they use the calls to screen patients who we think can be managed at home. So the consultant tells you these investigations are exactly the same as what they would have had if they came to the hospital, but these investigations are done at home using our community workforce. Because we're in an integrated trust, it makes it easier, but it can be done elsewhere as well. And the patients are looked after at home. Almost everything, as I said, what we do in the hospital, we do it there as well. And instead of admitting them in the hospital bed, they are actually admitted on a virtual ward. And I can go through that in detail if you want. But what we have done is, in the previous slide, it was less admissions. Now it is less conveyances. So patients are not even hitting the hospital by doing this. And by doing that, this is our data, 54% admissions avoided. That is, and we've consistently shown that nearly half of them you can actually stop the admission and manage them at home. And this is what happens to those who are managed at home. Not everyone needs community services. Only 68% normally needs, and that's not even at the level of an ACP. Sometimes you need far less than that at home. 15% were referred back to the GP, some in hot clinics, some needed, just advice, and some were triaged to a telephone follow-up. So this is what can happen at home. There are some myths that people think patients need to come. This is what paramedics think, that they need to come, but the conversation that you have with the consultant changes that from a barn door conveyance to a non-conveyance. So paramedics sometimes think that, if the patient is on the floor for more than 4 hours, they'll need to be conveyed because they need bloods. Yes, they do need bloods, but we can do them at home. Saturations, if they're less than 90, they need to be conveyed. That's the myth. And actually, no, we can actually do a lot of monitoring and care at home. Similarly, I won't go through all that, but the other myth is if the GP has called for an ambulance, they need to be conveyed, and we can't argue with the GP. Yes, you can't argue with the GP, but the conversation will tell you that you can actually manage a lot of these patients at home. GPs give up at a point where they need more investigations and sometimes more IV, fluids and IV antibiotics. But we can do all that at home, and so that's also something which we busted with our paramedics. So the key messages I would say is if we can actually get to the point where our patients are not calling 999, but call our frailty services or a care navigation hub directly, it will be useful. So avoid calling 999 if possible. And where possible, avoid a conveyance and use a virtual ward at a hospital at home. And again, where possible, even if they have to be coming to a hospital, avoid ED and acute medicine. And if they can go straight to the right team first time, it will be good. I'll stop there. And how am I doing for time? Is that okay?
Jyothi, you did brilliantly, actually. You really did. So I'll just meet the new attendee, if that's okay. And then, yes, we've got a good 7 minutes for questions, Rob, if there's anything in the chat, and then we'll go over to Sarah. Thank you so much, Jyothi. That was great.
Yeah, that's a whistle-stop tour, Jyothi. That's brilliant. Thanks, Wendy. Yeah, we've got a number of questions. If we can do a bit of a quick fire one, then we should be able to get to most of them, Jyothi. Let's start with the first one. Some of the data on the 4-hour standard, that's 2018. Is there any more up-to-date data on that particular point, Jyothi?
Yes, I can do that. I was just showing how we actually moved the frailty from ED and the effect of that on your ED performance. But yes, in between, as you all know, COVID hit and all our processes were, changed, and we are back to the old pre-COVID times now. So I can get you the new ones as well. But just to show that if you move frailty out of ED, that is how your ED will perform.
Brilliant. So it gives us a sense of the impact. Yeah. Thanks, Jyothi. The next question is, I've morphed the question a little bit. The question was, how many beds does your unit have? But also, I'd like to ask within that, what is the staffing model and how many patients do they see as opposed to the number of beds? Because I think the beds is just a fixed model. The amount of patients you see is perhaps a better indicator.
Yeah, so basically, as I said, we had 56 beds as one large acute medical unit, and we just divided that into 30 going to acute medicine and 26 coming to us. And out of those 26 in frailty, very quickly, as I said, we started off just two queues is what we started, but from that we could actually convert one of those bays, 6 beds, into an assessment unit. And we very quickly we realized we need 2 bays for assessment as well, because we need 1 female and male, because as soon as there is 1 female patient on one of our assessment unit, we can't get a male in from ED. So, and that's only because although it's an assessment unit, when they come via ambulances, most of the paramedics, they'll bring them after they've fallen at the middle of the night. So they're in pajamas. So if they're in pajamas, we can't mix male and female. But if they were dressed, we can actually mix male and female. So we needed the 2 bays so that we can get through those. So now if on a good day, we have 12 beds for assessment. And the rest is, short stay frailty.
Fabulous. Wendy, do stop me when I've run out of time. When you just tell me to put a sock in it. You painted a compelling picture, Jyothi, at the beginning. Who did you need to convince, and how do you currently hold your nerve when your site's under pressure?
Okay, who did I need to convince is a good question. So when we did our first PDSA way back in 2017-18, when we were doing it, I thought I had to create, we were doing the PDSA for 2 weeks, and I thought I had to collect a lot of data to go and take it to my chief executive. But by the end of the second week, I didn't have to do anything. The chief executive came and walked into the Frailty unit and said, "What are you doing here?" Because the whole place is moving very well. You know, the system is flowing so well. So the business case which we needed to do was, because they were doing 9 to 5 before, and all they needed to do was 8 to 8. So the extra hours in the, which we needed, that was all the business case we needed, and it didn't need any convincing at all. It just showed how easy it flows, the whole system, if you do that. And the business case was just stamped for the extra staffing that you need. All we did, all the people were already there. The therapy staff were there. Everyone was there. We just needed to bring them all to one place. And so the communication is much easier, and the patient care is much quicker.
Brilliant. So you demonstrated it in action.
In action,
brilliant. Yeah. Have I got time for one more quick one, Wendy? Okay, brilliant. There was a note in the chat box around urgent care, around some of our messaging to avoid some potentially ageist systems of care around some of our language and that. And I think that's a really important point to recognise across this piece of work. And there's a question then from Emma, was have you seen a reduction in people waiting for social care as a result of the work you've done? I suppose we could all use this as a balancing metric. If we're turning around people quicker, if you like, and the need for care may diminish. I don't know. What's the answer, Jyothi?
Absolutely. I think this is something which we'll have great difficulty proving, because you don't know what they would have needed if they stayed in the hospital. So it is always a guesswork. But what I know is that they needed less care, less packages of care in the long run, in a few months. But that is all I can tell you. Whether that was directly because of this or not, I don't know. I do want to talk about that age thing. It is actually very important. Thank you for raising that. And the only reason I hate it whenever I say over 70s and over 75s, it's just because it is easy to have an age as a surrogate marker. What we didn't want to talk about, give our paramedics, is a long list of criteria to say this is frailty, because then if it makes it difficult for them, they'll not do it. Age is easy to recognize, and that's where we're using. So pardon me for using age. That's not the intention, but it's an easy surrogate marker of frailty. And you can cut the data at whatever time. It's easy for data as well.
Brilliant. Thank you, Jyothi. Wendy, that's the end of the questions. Is that okay? Thanks, Jyothi,
yes.
very much. Half an hour with Jyothi is precious time, isn't it? You get a lot of information.
Thanks, Rob, and thanks for everybody that put questions in. So carry on thinking of your questions, and we will have time at the end. I'm just going to hand over to a community colleague called Sarah Mercer, who's going to present a slightly different picture of frailty, but really important project that her and her colleagues have worked on. Over to you, Sarah.
Thanks, Wendy. I'm just going to share my slides. So can you all see those? Fabulous. So yeah, as Wendy says, we're a community service, and this is about a service evaluation that myself and consultant practitioner Abby Barkham completed starting the summer of 2019. So again, this is a pre-COVID thing, but I'll sort of finish with where we are now a little bit. So really the point of this is to explain taking a very, very small service. So we ran a pilot project looking at a kind of community-based 2-hour rapid response. It sort of coincided with just when the NHS long-term plan was sort of announced. I think my boss, Abby, had the foresight to kind of see what was coming, and we were really ahead of the game on that. So we were trying to demonstrate what these sort of urgent community responses could look like. We went for an advanced practice-led model, looking for people with decompensating frailty and trying to reduce those acute admissions that Jyothi was talking about, what we can do to stop people even hitting ED 119999, all those things. So this is about how we got a fully commissioned service by the end of it. So our evaluation strategy. Now, I do have a PhD and I know how to do a service evaluation, and I fully admit this was a little bit scattergun. We went with it. Let's just measure everything because we don't quite know what we need to know yet. Broad themes: who are the patient group? What do they need from us? And what sort of value does the service add, or potentially not? That's the stuff we wanted to find out. So in our measure everything, we captured an awful lot of data, much of which we probably never used again. And some of the most important bits were things like our length of stay. So our service didn't really have any restrictions in the pilot phase. We didn't have a length of stay limit, things like that. So that's where this graph showing, you know, a typical length of stay was really, really helpful. And going forward allowed us to go, you know what, 2 weeks works really well. That's going to capture most people. And also when we kind of did a deep dive into all those outliers, it's sort of understanding that their needs no longer felt urgent response type service, but actually were in maybe an unmet need or just needed other service, sort of heart failure management, sort of teams like that, and gave us a bit of justification for how we partnered up with those services. Time of day of referral was really important going forward. Then and now our bulk of referrals came from GPs, and as you can imagine, phone lines open at 8 AM, and by the time the GPs sort of work their way through a triage list, they're on the phone to us between 10 and 11. And we would understand that, you know, that sort of middle part of the day would be where we needed our core staff members. One of the most useful things we sort of monitored was we just tracked every patient's journey and every clinical contact they had, who did it, what happened, you know, what was needed. We were operating with a very small team, quite a highly skilled team. We had 3-4 advanced practitioners from trainee advanced practitioner level up to consultant, nurse, physio, OT, another nurse. And sometimes, because we were so small in this pilot phase, we would have a consultant practitioner doing a repeat set of bloods. So probably our optimum modelling was the thing that really helped us going forward in presenting to the CCG what we needed. So actually, yes, it was a consultant practitioner doing those bloods, but going forward, support worker would be able to do that. So that really helped us build our staff model and present that. We currently operate with 10 trainee advanced practitioners, myself as trainee consultant and a consultant, and we get a lot of criticism for being a very highly banded team. And this sort of data was what really backed up that, no, this is what the patient group need, this is how you manage frailty. We have lots of support workers too, and they are crucial, but, you know, we're able to justify who we've got and what they do. This is a little bit of professional curiosity for me, perhaps. I just finished my frailty PhD and liked sort of looking into how we capture frailty. We did have a referral criteria at the start of moderate electronic frailty index or above from GP data, mainly because we knew they were using it and it seemed like a good way to stratify who we needed. I found it really interesting that once we'd done our comprehensive geriatric assessment and used the Rockwood clinical frailty scale, these two graphs show same sorts of categories, so fit, mild, moderate and severe frailty, same people, but actually the EFI was sort of overclassifying it. So the moral of the story for us was going, we're not going to bother with EFI. It'd be lovely to have a way to just get sort of pure frailty, but actually we started talking more to people about presentations and things that sounded like decompensating frailty instead. One of our key things was about getting our stakeholder perspectives. So I have a short video from one of our GP partners. Now we did do things like Survey Monkeys and lots of free text discussions to find out what worked for them, what didn't. But when we were presenting things back to the CCG and looking for funding, these stories actually had way more impact than I would have thought. I suppose being a scientist, I was expecting them to go need hard data, but they really like these stories. So this is just the, you know, do you use other things? So I hope I shared my sound. Please shout at me if it doesn't play. Oh, hang on, I've gone into the wrong one.
Some patients measured community quantity and ensured the rapid 2-hour assessment and intervention by a multi-professional team, namely the expertise of a nurse, an occupational therapist, and a physiotherapist. This is invaluable for our patients. The excellent follow-up is also good, sometimes more than once a day. This is excellent care and support for our patients. The only problem is that when they come out of the non-urgent setting, they want the same sort of dedication from our GPs, and I have to remind them how spoiled they are. The urgent community response has meant GPs can hand over care to a team that we have an excellent clinical collaborative relationship with, whom we trust with our patients, so that we can then concentrate on what's going on in the surgery on that day. This means that we are no longer distracted by thoughts about what we have to do and organise in the community. It has meant changing our practice to a certain extent, knowing that the team is there ready to support appropriate patients professionally, sympathetically and efficiently. I'm now able to concentrate on visiting my patients who have long-term needs but are not in acute need.
And I suppose for us, the real key bit was patients and carers. Does this work for them? Is it what they want? Now, we have included this video, and every time I share it, I have to apologise. The sound quality is not good, so please turn up your speakers because it is at the maximum that we can embed it at. But I just think it's a really important message to share.
My name is Lorraine, and I'm grateful to have had the opportunity, or had this opportunity, to tell you about my experience with the urgent community response team. I care for my elderly husband Brian. He's 87 in a couple of weeks' time and has needed full-time care since 2009, when he had the first of 2 serious hemorrhagic strokes. A recent bout of sepsis has made him even more vulnerable. So one morning in November last year, I couldn't get Brian out of bed, and I couldn't engage with him either. So I'm his sole carer, and he's doubly incontinent and wears a convene, so I knew I was in trouble and needed help. That was when I first made contact with the urgent community response team. It's a wonderful service, and it made all the difference in the world to both Brian and myself. Without it, I simply could not have coped. The UCR team meant that Brian could remain at home. It meant that he was not going to be taken away to hospital, and that was something that actually filled me with dread, especially at the moment. With their help, I was able to continue to support and care for him in his own home, and that was just so important, even more so at these very difficult times. The UCR team, to me, were like the medical cavalry coming over the surface, over the top. They're coming to our rescue. A first-class team of professionals from various medical disciplines, each bringing their own level of experience and personality.
So obviously CCG, they love the stories, but they also want cold hard facts. And our acute admission rate during that sort of 9-month pilot was 12.4%. We were able to work with our local partner acute trust to kind of translate that into a cost saving of 6 million per year for our Mid and North Hampshire division. I suppose that was really the bit that helped get commissioning pinned down and looking at what happened. So then we had 1 PCN, 50,000 people. We were taking GP ambulance referrals and had 6 staff working Monday to Friday. The result was a fully commissioned model, funding for 3 million a year. So if we think back to that 6 million cost, that's 3 million saving for the system for, you know, not the hugest area, and we translate very well elsewhere. We've expanded, so obviously still our primary care colleagues we work very, very closely with, but ambulance direct from ED, so people who do hit the ED, but actually could we spin them around really quickly and get them home, you know, within a few hours and support them at home. 111, and we're just working on getting direct access to the 999 stack, again, to see if we can even stop an ambulance going out rather than them going out ringing us. 60 staff working 7 days a week, 8 till 8. And I guess the thing was our stakeholder opinions are so important, and we don't want to lose sight of that, even though we're fully operational. So we've just engaged in a care opinion trial, which gives us really that kind of rich personal data about what works for people. It allows us to close the loop very quickly. So if we get feedback, you know, sort of, oh, I didn't know you were coming, or things like that, we can think, well, what can we do about that? And because we captured lots and lots of data, we were able to work with Wendy and colleagues and give them lots of understanding about sort of demand and capacity modelling for similar types of services, and something that, you know, we can continue to look at, informs our staffing, rotas, all that kind of thing. So that's where we are now. We'll stop sharing.
Hi.
Thank you so much, Sarah. Thanks, Rob. Are there any questions in the chat for Sarah or even Jyothi?
It's actually slowed down on the chat, and I think that's mostly purely because it's quite a compelling case that you're putting forward there, Sarah. And I apologise for misspelling your name in the chat box. But I've got a couple of questions, Wendy. Would that be okay to?
Yeah, and I've got one as well, Rob.
Okay.
So between us, hopefully we'll cover what most people are thinking.
It was lovely, that summary slide where you outlined potentially what might have happened if you weren't there, i.e. the savings that you've delivered. How, as interest in certainly community services have increased, has been a solution to so many things, both from the avoiding admission and for the things like early supported discharge. How do you reconcile what's the best patient cohort for you to go for? If you were going to look at the skills across your team, where would you target them if you could have a free hand?
Yeah, I think a lot of what Jyothi was talking about, of, you know, frailty does not do well in ED, it does not do well in acute, full stop. And getting in there at that point where the urine infection, chest infection, COVID starting, and keeping people at home. So it is very much people who are vulnerable to those minor stresses, a complete frailty picture. We are a service now that operates over the age of 18, and sometimes we have younger people with sort of complex long-term conditions. And again, that's your younger frailty, isn't it? You know, it's seeing it in that age group. So yeah, it's people who really benefit from that treatment at home. We try not to be too restrictive. We see patterns of things, you know, it's much more those presentations. It's the small stressor, big response type stuff that we do really well. But, you know, I think we've got space to grow. I think we can offer more in the community. We're not yet doing sort of IVs and things like that. That's probably the next steps.
Thanks for that, Sarah. Just one other thing about time of call versus time of recognised need, if you like. And I noticed you built your demand and capacity based on when you get the referral, if you like, from the GP. You mentioned you're trying to access the ambulance stack to try and work left shift your demand, if you like, to understand when it happens. Is there anything else you've got in train to identify your services nearer the point of need, and dare I say it, without other levels of triage, if you like?
It is tricky, and I think, you know, we find, because we're a patch in Hampshire and our partners are South Central Ambulance Service who work across, you know, 3 counties, I think, that it's very hard to get the nice responsive services that work, and it has taken a long time. And I think also this patient group are still very of the I ring my GP at 8 in the morning mentality.
Yeah.
You know, they suffer over the weekend and they ring in. And we are starting to now get, it's not on the slide actually, we take repeat self-referrals, because we do get a lot of people that we start to know very well. And that's great. If they can just ring us, they said, yep, you guys worked for me last time, I need you again, then I think that's a really helpful way in as well.
Brilliant, that's lovely. A little bit of local feedback for you. My next door neighbour has just benefited from your service.
Oh, amazing.
literally in the last week.
Amazing.
So bless you on that front. There's a hand up from Nina Mather. You've got a free hand there, Nina.
Yeah, I was just wondering, do you take my team does admission avoidance in the emergency care, so straight from A&E. We are struggling to get a pathway out for frailty at the moment. It's something that we're trying to get partners together with. Does your team accept referrals straight from A&E?
Yeah, we do. We have with 2 options there. We have our own community inReach team based in the hospital, so that's probably the primary one. We do work really closely with the ED colleagues. I assume it's the same in most EDs, as there's a lot of flow through staff in EDs, and it's one of those things of having to continually build those relationships and the awareness. I mean, we've got our posters all over the wall and they can ring us, but I think once people know then they use, and word of mouth always your way forward there.
Yeah, we're a team that in reach into A&E, but that's our main focus. We don't go on medical assessment wards or anything like that. And we consist of OTs, physios and nurses on our team, cover 8, 6, 7 days a week. For pure admission avoidance, but before the pandemic, we had great flow out, but it's been much more difficult since, and we are so keen, this team, to get frailty patients seen in the community in a virtual ward, and it's something that we're working on, but we're not quite there yet.
Brilliant. Over the course of this, are you guys able to connect over the course of this in terms of email? Because I do think that's the beginnings of a little conversation there, Nina and Sarah. Wendy, are we okay for time? Sorry for checking back on you. Are we all still
yeah, no, absolutely.
Brilliant.
Carry on, please.
Emily, you've got your hand up. Nice to see you this afternoon.
Hi, yeah, thank you, Sarah. This is fantastic what you've set up. It's I just wondered around access into the more longer term rehab services, and with reablement, were you able to easily access that, and also with their social worker affiliation with the team?
We don't have a social worker, but we do work very closely with our adult services colleagues. So their community reablement team were commissioned at the same time as we got our big commissioning done, and to do that kind of 2-day response admission avoidance work. So yeah, again, just a phone call into them, we get that set up. Very exciting pilot on the horizon, which I didn't mention, I didn't remember about it honestly, but we are working with Age Concern Hampshire, and they've just got funding for a pilot for a year to have sort of between 2 and 6 care staff embedded within our team to actually start that reablement work straight away, because CRT, adult services version, are great, but like social care across the country, stretched at the minute, and we were just sort of thinking, well, if we could have our own care staff that do that intensive work, do we even prevent that need for the 6-week stuff if we're in day one supporting and get it done within 2 weeks?
That does sound really powerful, because it's that holding your nerve when you recognise frailty, people are struggling, if you like, in that space between then and when things can wrap around. That's a really good bit. Wendy, I'm going to hand back to you now. Is that okay? Thank you so much indeed, Sarah, and people, for their contributions.
Thank you so much. Now I was just going to ask you, Sarah, a little about access to medical colleagues, because obviously you're a very autonomous, highly skilled clinical team. But if you did need the support of a geriatrician, or you needed a diagnostic in the hospital, how do you manage that?
Yeah, we're very lucky in Hampshire hospitals have a great service in their clinical communications line, which then they have a frailty option within that, which is great. You get a geriatrician at the end of the phone to talk anyone through. We're one of the few divisions in Southern Health that doesn't actually employ a geriatrician, and we're a little bit proud of that. I realise there are a lot of medical colleagues on this call, but we kind of, we appreciate working closely with geriatricians and other medics, but actually we're quite self-sufficient. So, we have it, we use it. We don't have anyone embedded within our kind of trust itself. So.
Oh no, thank you. And it sort of links back to Jyothi's model, isn't it? The fact that frailty it's there's a pathway from community to hospital back to community, and patients may need to step up into the acute for a more complex assessment and diagnostics, but then they can come back home again. And I think it's just everybody working together that's really helpful. So I've got another couple of slides to share with you all, if that's okay. If you've got any last questions, please do post them into the chat box, and Rob can pick those up. So as I said before, all our resources and all recording of any of our webinars along this whole programme will be within this platform here. We'll send the slides out and you'll be able to access direct from the slides. We've got a Futures Network pages that is owned by our team, ESIS team, but we also have got a dedicated space for the hospital only programme as well, where the resources are a little bit more condensed into there. But as I say, the YouTube video, anyone can access those because they're on YouTube, and please do share them with your colleagues. Just want to advertise our next event. So we've done event 1 and 2. Our next event, Learning Event 3, is going to be focusing more on deconditioning. We've got one of our clinical directors, Amit Arora, talking to us around deconditioning, the work he's done with the East of England. And we want to talk a little bit about the impact of deconditioning on people's lives. That's on the 26th of July. And then on the 20th of September, so we're breaking for a little bit for the summer holidays. On the 20th of September, we'd like to hear from you. So what we'd like is an hour to hear your stories and your learning over this year, or any new services that you're testing. So you can talk to us and share it with us. We'd really like that. And if you contact Rob, who's on this call today, his email address is on the slides there. But I think today it's really, really important, isn't it, that we've spoken about the value of testing things, and you can start small and test things and evaluate and share the information, whether it's data of length of stay or data of admissions, alongside stakeholder feedback and patient stories. It's so valuable. And I think the biggest thing to remember is the value of the enthusiasm and commitment to supporting patients with frailty, making sure they're supported in the right place for them at the time. So I'm really pleased to have shared this webinar with you. We'd love your feedback, because we like to just make sure we're doing things right. And if there's anything you'd like to share around this webinar, the QR code is on the screen now. Crystal, are you able to post it into the chat as well? And that would be great if you could just provide us with some feedback. Fantastic. I'm going to stop sharing, and we've got a couple of minutes. So you've got a choice of a cup of tea, or if there's any last questions or comments, please raise your hand. We'd be lovely to hear from you. No worries at all. Why don't let's everyone have a 5-minute break. Thank you so much for joining us.